who is the Chief Development Officer at Brainstorm, is going to discuss the relationship between CSF biomarkers and treatment efficacy of NurOwn stem cell therapy.
Thank you. Thank you, Bob. And thank you for the opportunity to share insights into the rich biomarker data from our phase 3 trial. It's important that I provide some context before I go into the objectives for today and the results, because the broader context of the trial actually drives some of our objectives. And as we've published this trial, you'll likely be aware that this trial included participants with advanced ALS, resulting in participants hitting a floor effect on the ALS-FRSR. And as you can see by the footnote on this slide, about a quarter of participants had ALS-FRSR values of 25 or below at baseline. And how the patient population from our phase 2 trial compares to that of other late phase ALS trials can be seen in this graph. So the blue dot is the average baseline from NurOwn's phase 3 trial, which had a baseline value of 31, which is 11 points or almost a quarter of the scale lower than Adarabone's J19 trial, and 5 points below Amylex's registration trial. So this highlights the uniqueness of our trial population, which is a strong outlier from other late phase trials. And why this matters in particular, or is extremely important, is on the left side of this slide, which is that in these participants with advanced ALS, almost 40% had values starting on the 6 items in the fine and gross motor that were starting with a value of 0, which confounded the analysis in the trial. It definitely contributed and may have led to NurOwn missing the trial's primary and secondary endpoints, because we know that once a value of an item on a scale reaches the value of 0, the scale cannot measure ongoing disease progression in trial participants, which also impacts the ability to differentiate rates of clinical decline between treatment groups. And there's a piece that is further confounding, which is that the rate of zeros on fine and gross motor in particular, Jeremy Scheffner has estimated that about 70% of decline observed in trials occurs in these 2 subdomains. So that even further confounds the impact from these 23% of patients. So where the scale is not effective, it's really important to verify the biological effect that's observed through biomarker data and to see if it's consistent with those participants that are in the remainder of the trial. And if the effects across biomarkers are consistent, this would provide confidence that there's a biological effect in all participants in the trial, and the possibility that participants could also be benefiting from the treatment clinically that we're just not able to measure with the scale. So inclusion of these participants with advanced ALS and those in the lower half of the scale at baseline impacted all of the clinical endpoints that employed the ALS-FRSR because of the inability to measure ongoing clinical decline. So the floor effect needs to be addressed before you can draw valid treatment conclusions from the data. And this slide suggests, the data on this slide suggests that there is a NurOwn treatment effect in participants in a pre-specified subgroup with less advanced disease across 2 endpoints. So on the left of this slide, we have the primary endpoint for the study as a clinical response analysis. And on the right, a key secondary endpoint, which is commonly used looking at average changes from baseline to the end of the study. And as we published in Muscle and Nerve in January, NurOwn failed to demonstrate a treatment effect in the overall study. So for both of these endpoints, you can see the first set of bars show the primary and the secondary endpoint in all participants. And you can see that there are no meaningful differences between NurOwn and placebo. However, if you look at the bars on the right of each of these endpoints, which is a pre-specified subgroup, and more importantly, minimizes the floor effect that's observed in the scale because we've moved away from the end of the scale, the estimated treatment effects is clinically relevant on both endpoints. So with the primary endpoint, we see a 20% higher response rate with NurOwn compared to placebo. And on the secondary endpoint, we see that 2 points of function are preserved with the NurOwn treated patients compared to placebo, which, as updated in the erratum, which was published in August, is anomaly significant, has anomaly significant p-value of 0.05. And this treatment effect holds across post-hoc sensitivity analyses that cover a broader set of trial participants, including if we look above the baseline score of 26 and include all participants above that value, that baseline value, which also is minimizing the floor effect and includes about 75% of the total study. We've published these. They show that across these participants that at least 2 points of function are preserved with NurOwn treatment, and this finding has nominal significance across all of these thresholds. Lastly, once the floor effect is minimized, the evidence from the trial aligns with the power calculations. So we estimated when we were planning the trial that we would see a 15% response rate in placebo based on the patient's criteria, the inclusion criteria at the trial, which was derived from historical data using PROACT. And the 35% assumed response in the powering calculations for NurOwn were derived from earlier clinical trials. And we can see that the data aligns very well with these assumptions. The biomarker data that I'll now go into provides another reason to believe that the floor effect of the ALS-FRSR scale is really the key insight, explaining what we learned from this trial. And it's a phenomenon that once we understand, can be appropriately accounted for. So our objectives for today are to evaluate CSF biomarker data from our phase 3 trial, observing treatment patterns across pathways that are important to ALS disease. What James Berry described yesterday as really upstream biological events. We used pathways of neuroinflammation, neurodegeneration, and neuroprotection. And today we'll look at individual biomarkers, and we'll also look at analyses or multivariate analyses that are allowing us to look across biomarkers, both of which reveal large changes across biomarkers following treatment with NurOwn, while values on placebo remained unchanged. These multivariate analyses are analyses that really allow us to look across multiple biomarkers, are especially important in this complex disease. And also as we evaluate NurOwn, which is a novel autologous cell therapy that's pluripotent and could affect multiple pathways. We believe it's not realistic to have any one biomarker that sufficiently measures the effect of NurOwn, nor is it likely that any one biomarker can sufficiently represent the complexity of ALS as a disease. So both of these analyses are important, both ways of looking at the data. We'll also look at patterns in the biomarker trajectories in participants who were more greatly impacted by the floor effect of the scale. And we'll see that treatment effects in biomarker data from all patients in the trial look similar to participants most likely to be impacted by the floor of the ALS-FRSR. And across the biomarker data, we don't see a floor effect. Lastly, we'll review pre-specified analyses from statistical models that let us draw the conclusion that the changes we observe in the ALS biomarkers are biologically relevant to the clinical outcomes observed in the trial. And more importantly, that we can predict the clinical outcomes in the trial with biomarker data. So very fast, a review of the study design. This was a 200 participant trial in ALS patients receiving 3 treatments of NurOwn or placebo that were administered intrathecally 2 months apart in a 1-to-1 randomization ratio. Biomarker data were collected in all participants in the trial, and the analysis that you'll see today summarizes data in all trial participants. We collected CSF biomarkers 7 times across the trial, both prior to and following each treatment. And from a trial perspective, the study had very high completion rates, above 70% in both arms, and randomization was very effective, including across subgroups, which allow us to enable subgroup analyses where randomization is preserved. The samples were analyzed using validated assays from established labs. And we had an independent and a second analysis plan that was dedicated to biomarker data, which was submitted to the FDA prior to the unblinding of the trial. Given the skewness of the biomarker data, we log transformed the data for proper analysis so we didn't violate assumptions of the methodology, and we'll display the data today accordingly. The three primary analyses that I'll cover today, one, we'll start with principal component analysis, which allows us to look at trends across biomarkers. It's a powerful visual approach that allows us to see trends across multiple biomarkers. And then we'll go to individual biomarker trajectories that were across the trial using a mixed effects model. And then lastly, we'll use a mixed stepwise regression model that was used to identify biomarkers to predict clinical response observed in the trial. And to enter the model, a biomarker term had to have a p-value of 0.25 or less. And then the machine learning algorithm iterates, allowing biomarker terms to be selected and removed until the final set of terms are selected, which required the p-values with those biomarkers to be 0.05 or less. So thus identifying the most relevant markers. The relationships between biomarkers and clinical endpoints focused on two clinical endpoints, both which were pre-specified. First, the clinical endpoint, which was the primary endpoint of the study, and this has already been published in Muscle and Nerve, and therefore I'll make just high-level comments today and won't present it in detail. But there are complementary findings to the results to the secondary endpoint that I will summarize today, which focuses on the rate of decline in the treatment period, and will employ a measure that is derived from a piecewise slope model. So we analyzed a total of 33 biomarkers in this study that were grouped into neuroinflammation, neurodegeneration, and neuroprotection. And given the limited time I have today, the graphs, the individual biomarker graphs that I'll share with you are really illustrative of the effects that we've observed across the trial. And we're in the process of writing a manuscript which will provide a comprehensive view and cover everything that was collected. So starting with principal component analysis and allowing you to see how biomarkers across these pathways changed between treatments. The graph on the right side, you can see the first panel is NurOwn and the second panel is placebo. And what principal component analysis allows us to do is to describe the relative patterns between treatments, that instead of looking at 33 biomarkers individually, we can actually look at a summary. And the principal components are created using uncorrelated variables. And we'll focus on the first principal component because it actually summarizes the greatest amount of information. So what we can see looking at this graph in blue, markers of neuroinflammation summarized by this principal component decreased with NurOwn, while placebo inflammatory markers summarized by this principal component, the levels remained high. Markers of neurodegeneration decreased with NurOwn, and placebo neurodegenerative levels decreased across the study but remained elevated relative to NurOwn. Lastly, in green, the neuroprotective markers increased with NurOwn treatment and were maintained over 20 weeks, while placebo neuroprotective levels remain low. These patterns are consistent with NurOwn's multifaceted mechanism of action, which gives us confidence as we look at effects across multiple biomarkers at the same time. And while I'm not going through the details, I have included the biomarkers that were selected by the PCA methodology on this slide. And also for you to be able to see that large amounts of variability in the biomarker data were effectively summarized by these principal components, which is the goal. So it was very successful. But let's turn to a few individual biomarkers that are grouped by pathways. So we'll start with neuroinflammatory markers, which are in the first column. We have two examples, markers of pro-inflammatory MCP1 and anti-inflammatory marker LAP. So we observed large reductions in inflammation across many biomarkers. With these two in particular, you can see that we have a very significant treatment effect with a p-value of less than 0.0001, which occurs early in treatment. The first biomarker measure is taken 2 weeks after the first treatment. And we see the reductions in inflammation are maintained through the duration of the trial. In fact, both of these biomarkers have greater than a 20% change from baseline at the end of the study. You can also see there are many time points which show significant differences between treatments, which are noted by the asterisks. Across markers of neurodegeneration, we observe reductions across the study, including some that are statistically different from placebo. But given the prominence of neurofilament light in ALS, I'm highlighting this data here today, and we can see that following treatment with NurOwn, we see a slight increase in neurofilament light levels, which is consistent with values observed following intrathecal procedures. And these steadily decline across the trial, reaching a 15% reduction from baseline at week 20 with NurOwn. The difference at the end of the study at week 20 are not different between treatments, but there is a significant effect over time. And it might be that we simply haven't measured neurofilament light values for a long enough period, which is something that our expanded access program, which is ongoing, will provide insight into. With neuroprotective markers, we see large increases across biomarkers, as illustrated on the slide with VEGF, where we see a greater than 300% increase in values at 2 weeks, and values remain above 150% from baseline at the end of the study. The differences you can see at all time points in the overall treatment effect are highly significant. Given the floor effect that I framed at the beginning of this talk that was observed in the ALS-FRSR in participants with advanced ALS, we wanted to look at these 4 illustrative biomarkers we've just reviewed, and to look at their trajectories in these biomarkers in participants that have ALS-FRSR baseline values less than or equal to 25 and greater than 25. So we're really looking at participants that have advanced ALS at baseline and those that have less advanced disease. Starting with the inflammatory markers on this slide, as with the graph you just saw with all participants, across both subgroups, we observe large differences between NurOwn and placebo at 2 weeks after treatment, indicating that there is a treatment effect in reducing inflammation quickly following treatment with NurOwn. I don't know that you can see the text that gives the p-values, but the interaction terms, the fact that these are large p-values, tells us there's no statistical difference between these subgroups, which I think you can visually see as well. With our neurodegenerative biomarker neurofilament light, we observe in participants with lower ALS-FRSR baseline scores, the participants that were randomized to NurOwn have higher neurofilament light values at baseline, in addition to actually larger declines in neurofilament light across the study following treatment. Also, you note from this, irrespective of the baseline values, neurofilament light values decrease after treatment with NurOwn for both subgroups, and placebo is relatively flat. Lastly, with the neuroprotective marker VEGF-A, the data by baseline ALS-FRSR value, we see that VEGF values increase rapidly across both subgroups with NurOwn and remain elevated relative to placebo across the trial. And we've looked carefully across all of our biomarkers. I'm giving you only a sample, but we do see that changes are consistent regardless of which of the subgroups we look at across the biomarkers we measured, which represent ALS patients with more or less advanced ALS disease at baseline. And this tells us that NurOwn is having similar effects on these participants, and that the reason we see differences in the clinical endpoints across subgroups is due to the limitations of the ALS-FRSR scale caused by the floor effect. But one of the most important analyses done on our biomarker data allows us to connect biomarker data and clinical data, and allows us to conclude that the biomarker data can predict clinical outcomes observed in this trial with high accuracy. And as published in our Muscle and Nerve paper, relating the biomarker data to the primary endpoint, this stepwise model I described selected 6 terms, in-cal survival, prediction term, and 5 biomarkers, which spanned neuroinflammation, neurodegeneration, and neuroprotection. Neurofilament light happened to be the marker that was selected from neurodegeneration. The ROC curve supports that the predictive value of the biomarker data for the clinical response of our primary endpoint was exceptionally high. There was an 82% area under the curve, the ROC curve. When this analysis was run on data that's really focusing on NurOwn and using the treatment, the data from the treatment period, so we're looking at the effect from the treatment rather than the change between the pre-treatment period to the treatment period. Again, we see that 3 biomarkers were selected in the final model, with neurofilament light being in common to the analyses that I just described from the primary endpoint. We can also see that the 3 biomarkers that were selected they span these 3 pathways, with LAP being a marker of inflammation, neurofilament light, a marker of neurodegeneration, and galectin being a marker of neuroprotection. This model also had very good statistical properties and great fit. So in conclusion, the biomarker data provides evidence that is consistent with earlier trials of a multifaceted mechanism of action with NurOwn. We observed changes in biomarkers associated with underlying pathologies of ALS that are well documented. Specifically, NurOwn elevates markers illustrating enhanced cell protection and lowers markers of neuroinflammation and neurodegeneration over time compared to placebo, which is biologically what we expect with NurOwn and placebo. We observe consistent patterns across biomarkers in participants with more advanced ALS at baseline compared to those with less advanced disease at baseline, with no evidence of a floor effect. And statistical modeling designed to identify markers with the potential to predict clinical response with 2 different clinical endpoints spanned the 3 pathways that we were interested in, markers of neuroinflammation, neurodegeneration, and neuroprotection, which emphasize and reveal the importance to all 3 pathways in predicting clinical response in this study. So in conclusion, we believe novel therapies that simultaneously target multiple pathways may offer great potential for ALS. And I want to close by thanking our PIs and their excellent teams and from their sites that conducted the study, and the trial participants, and certainly including Merit, James, and Bob, who are so central to the ALS ONE community as well. Thank you.
Thank you so much, Stacy. That's really one of the most comprehensive analyses of biomarkers we've seen in any studies, and we certainly appreciate it. We have, we're getting a little short on time, but we have time for 2 or 3 questions. So one question that has come from the chat is the following. Are you going to be looking further at the impact in the specified subgroup of patients carrying UNC13A risk alleles, the SNP risk allele? And how will that help you think about further development of NurOwn?
Yes, that's a great question. And certainly we've seen in this symposia the importance of underlying genetic information. We did present, we had a genetic substudy from this trial and was presented by Merit at MDA recently. And we will continue to learn over time and certainly use information to the best of our ability. What we did understand from the first set of analyses is that carriers, specifically with the AC phenotype, had a higher response rate than non-carriers. And there were limitations, I think, to the study in the fact that we had some small samples, as we know that some of these phenotypes are represented in a much smaller proportion of the population. Actually, our study mirrored the population very nicely. So there were a lot of things that gave us confidence to the results. The analyses that I think we can do that will extend the initial insights that we've already shared are really bringing them into the context of the biomarker data. And that is something we intend to do and we'll highlight in the manuscript which will really give a very full review of our data.
Yeah, fantastic. Thank you. Ben Brooks has asked, have you analyzed the time to 1 or 2 point drops in the ALS-FRS item scores individually?
Have we looked at the drops actually in points?
Yes. Yes.
So we have looked at our data over time. We actually see changes occurring very quickly, not only on the primary endpoint, as well as in the secondary endpoint, the average change from baseline. We've also looked at subscales, which I think is a great way of looking at the data. And we see that the subscales each of the subscales are contributing to the treatment effects that we observe in this trial.
Thank you. And the final question comes from Camille Mekawar. Are you planning on conducting another clinical trial recruiting patients at an earlier stage of the disease?
So yes, we are committed to continuing to learn more about NurOwn in an ongoing part of our clinical development process. We have shared that we intend to file our data. This was a phase 3 trial. We believe that we have uncovered very important insights, which will be summarized to the FDA in a new biologics license application. And it is our hope that this will be substantial evidence and that we can conduct a trial that would bring more information in the context of an approved therapy.
Terrific. Thank you. Thanks again for the